Support for this program is provided by the following.
Welcome back. That was an awful lot of information to digest, and we still have a lot more information to go. I'd like to tie up just one more part of the whole clinical trial discussion that we were having. I want to point out that OHC is the only CAR T-cell clinical trial program available for adults in Cincinnati. And Dr. Faber, tell the folks here a little bit more about how they can access that.
Sure. They're on our website, like many other centers. There's information regarding our CAR T program, phone numbers and emails on how to connect with our office and our hospital, Jewish hospital that we perform those at, and then as well as information about our clinical trial program. So,
thank you. Now, we've got a lot more people on the stage here. This is sort of like a Thanksgiving dinner table now. I can see you all the way down there. First up, I'd like to have a little conversation with John Benz. I'll give you a little bit of a detail about what he has gone through in a while. And then I'm going to ask him to share with you how he's dealt with a lot of what's going on. John was diagnosed in 2006 while caring for his wife, who was dealing with ALS at the time. So I like to operate under the only one healthcare crisis at a time in my household. John did not have that luxury. He's been in remission for almost 10 years. Till last year, like me, he had a recurrence and he's now on ibrutinib. John loves camping and fishing, and the reason why I'm sighing right now is because I know that fishing is just an excuse to drink beer, right? Absolutely. See. Fishing and camping is one of the most relaxing things a person can do. So I agree with you. It's a wonderful thing, and don't ever stop doing it. You have a life motto. Take it as it comes. Tell me about that. Tell me about your story and why you've decided to just take it as it comes.
Back in 2006, I was caring for my wife who had ALS, and I was diagnosed with CLL. Boy, that's a lot of letters.
It is.
In XYZ and T, whatever, But, and I had to put off treatment till her disease ran its course. Anyhow, after my wife passed away, I waited several months before I even considered treatment. I had to get my stuff together and everything like that. But life throws a lot of hard licks at you. And if you're lucky enough to be standing once you get hit, just keep on going with it.
Losing your partner, your loved one, your spouse is a difficult and almost insurmountable stumbling block in your life. How did you reconcile the need to get past that and start living again?
Well, I came to the realization that life goes on either with or without you. And I do have a younger daughter and a granddaughter who I have to live for. So I had no choice.
Tell me about your treatment. You're now on ibrutinib. Are you experiencing any side effects?
Yes, the fatigue, sometimes nausea. If I don't have enough to eat in my stomach when I take my daily med, I suffer the nausea, and the fatigue seems to get a little worse. But it seems to me if I got a full belly and take it, everything runs fine.
Outstanding. And I heartily endorse the concept of a full belly. Not too full. Not too full. Would you have done anything different in your treatment program?
I really can't say as I would. I just had to totally trust Dr. Essel.
Sounds good. We have a couple on stage, Dave and Linda. I had the good fortune of having dinner with them last night, and we had a lot to discuss. And one of the things we giggled about was the concept of team treatment, spouses being involved together in the treatment program. So what I'm going to do right now is I'm going to tell Dave that he can't say a single solitary word for a few moments.
That is so tough.
Linda, you're the caregiver, right?
Yes, I am.
And your husband, being a typical male, he was completely and totally truthful and forthcoming with his doctor visits, correct?
In his mind, yes.
Okay. Tell me about that.
Well, Dave is always, he never wants to worry anybody or, doesn't want to complain about it. But, so when Dr. Russell would say, as far as your pain that you might be in or whatever, it's like, it's not too bad. But when earlier in the day, he's like, oh my gosh, I'm like in such pain from my spleen or whatever the case may be. So he downplayed it just a bit.
Just a bit.
Just a bit.
Just a bit.
Mm-hmm.
So without trying to incite a riot here, doctors and nurse practitioners and nurse navigators, the first question that you ask of patients when you're seeing them in clinic, something along the lines of, how are we doing today, right? And we get nods going on. And what is the typical male response to that question?
Fine.
Thank you. Linda, they're not fine, right?
No, they're not.
Okay, let's go into a little bit of detail about what not fine is. What are things that you as the caregiver need to make sure that the medical team knows is going on?
Well, the fact that he was fatigued all the time. He would get home from work, have dinner, and he would be out cold for the night. And it kept getting worse and worse, as he was in the wait and worry stage, and his spleen started bothering him a lot. To the point where, he was in a lot of pain. It's like, that's definitely something that Dr. Russell needed to know. And the good thing about Dave, though, is he did a lot of research in that. So he would go into his appointments armed with questions. He'd have questions written down in that. So that was a good thing. But, he would always downplay the negative things that he was going through.
Of course. We're going to let you talk a little bit now. Tell me about what you love doing right now. What are your favorite things to do?
Right now, I guess my favorite things really, as John said, is just living. And in a interesting way, this disease has made me realize, the old cliche, live in the moment. It's never been more accurate in how I've dealt with the disease and how I deal with my daily life. I very much enjoy playing golf, and I found that golf was the one time, even when I was going through treatment, that enabled me to just forget everything and just be in the moment. And the one thing I'd suggest to anybody going through this is find that thing that makes you forget everything and be in the moment, because it takes the stress, the anxiety, everything away.
Expand on that a little bit. Tell me about how you achieve a quality of life that is acceptable to you, because it sounds to me like you have a more than average expectation of what living well is all about.
I think, and I made the comment, listening to everybody here, it was in many ways a trip down memory lane, because it's been 12 years for me, and some of the comments that were made, some of the discussions just brought back memories, and a lot of them good, a lot of them bad. But my expectation is just that. John said, about his daughter and his granddaughter. Look around, find something that is important to you, whatever it may be, and that is what you want to live for, and that's what you want to look towards. You can't change the disease. You can't change the progression of it, but what you can change is how you deal with your day-to-day life.
Do you have children?
One daughter.
I'd like to ask a question of you that can be somewhat of a delicate subject for many of us. How did you tell your child about your cancer?
Initially, we didn't. At that time, she was in 4th or 5th grade, and we were in obviously the watch and worry stage. And Linda and I made a decision that why worry a small child about something that may not happen for a few years. In my case, I think it was 3 or 4 years before treatment. But when we did tell her, we sat her down, and at that time she was 15, and when we told her. And so I explained to her, that, what I had, and I really told her what CLL is, and said that it's something that I said, I apologize, but we didn't tell you initially because, and I explained to her why. And I told her some of the impact, because like Linda said, I was always sleeping. To her comment was, I just thought you were lazy and Mom was doing all the work. And that was a tough thing to tell your child. But we're fortunate enough to have a child, I think, who really, I know she was worried. She didn't say it. In some sense, she's much like me. But she really then became a supportive caregiver, too.
So what treatment have you gone through?
I had, was it FCR, FRC, right?
FCR.
FCR, whatever. It's their letters. And, I had that, and it's something that Dr. Faber said, and I've made this comment many times in talking about Dr. Essel, who I also have. I went to Ohio State, or the Ohio State, the James, and had a fish panel. And in my thing, you'll see, there's that I had, they found, I think it was like 7 or 8% of my cells had the 17p deletion. And Dr. Lynn, who is at Ohio State, said, well, I know it's under the low end, I think it was 15 or 16%, to have some kind of a truly adverse impact on your life. But he said, your cells have it, so you have it. And that was the longest drive from Ohio State to Cincinnati. And I don't think we said 2 words to each other, because right now I'm dead in 18 months. That was the only thought I had. And I came to see Dr. Essel, and he opened the window and he looked out and he said, man, it was a day like today. And he goes, it is really cloudy. And I kind of looked at him and he said, you probably don't think so. And he said, that's what this test is all about. It's a tool. And it's a tool that I read about, and what Dr. Faber said, he said, but my job is to look to you as a patient and as an individual. And the biology of you is going to tell us the progression and the treatment of your disease. And so when I heard the term art, I realized that's what he was practicing, is the art of a practitioner. And so my suggestion to any of you is and John said the same thing, I trusted Dr. Essel with my life, and I still do. And I have all the respect in the world for him, because what I saw in him is somebody that saw me as an individual, and somebody that saw my disease as an individual disease.
Excellent. I mentioned earlier at the beginning of the program, we are a community. These town meetings bring CLL patients and their caregivers together. We have so many ways to get together in this world that we live in now. We have these meetings, which are great. We have in-person support groups like are provided by CLL Society and the Leukemia and Lymphoma Society. I mean, great support groups. Most of us are probably walking around with smartphones, and we have access to social media, and there are literally hundreds of CLL support groups available to each of us to consume as a buffet, as it were, as little or as much as we want. What I find really amazing is this gentleman sitting down at the end of the aisle of here. John doesn't do any of that internet stuff. Am I right? Do you have an email address?
I have an email address on my phone, but I don't have the internet at home. I don't have a computer in my house.
So you don't know what the latest Facebook trends are?
No.
And you probably don't care?
No.
Excellent.
And I'm proud of that fact.
Yet you're still here sharing your story with us because why? Why are you here?
Because I really have no choice. No, I mean, that sounds funny, but like I said, I have other people I have to live for, and I have no choice, but I have to live.
Dave, talk a little bit about your advocacy. I know that you try to give back to the community, give back to other people that are going through this not so pleasant road of CLL. What do you do?
Well, it's just not CLL. It's any cancer, and it's really to share my experience, my anxiety, dealing with Dr. Google, and the thing that anyone going through any cancer and again, I'm speaking from my experience. When you first tell friends and family, all of a sudden it's this weird feeling. It's like this wall all of a sudden comes up. Everybody walks on eggshells. And I found the way with myself and then also other people who are dealing with it and trying to talk about their cancer, which I mean, I would suggest, but maybe some people wouldn't work. I have use morbid sense of humor about my mortality, about my disease, and I have found that laughing and about the disease, about the experiences that you will may face, allows people to relax around you, and that's what I needed, was for people just to be relaxed around me and not feel tense. And so my advocacy, anytime I meet people like that, is to make them try to laugh and realize that, as John said, live the life that you have now.
Excellent. I'd like to echo your morbid sense of humor with a personal experience that I want to share with everybody online and here in the audience. Is anyone familiar with the term playing the cancer card? Okay, we got a couple of hands. Okay, in general, people who don't have cancer will point the finger at people who have cancer and say, you're playing the cancer card. You're trying to get something special. You're trying to get an extra benefit. So along the lines of this morbid sense of humor, 3 days after I was diagnosed with chronic lymphocytic leukemia, I found myself in Houston, Texas, at Citizens for Animal Protection. It's a pet shelter. I decided it was time for us to not have one cat in the household. It was time to have 2 cats in the household. And I was strolling through Citizens for Animal Protection, and I came across this cute little male brown tabby cat. And that cat stuck its paw out of the cage and made me stop walking, and I was like, okay, this has pretty much been taken care of. So far, so good, right? I was told that I could take the cat out of the cage. I took the cat out of the cage. We were playing. I was petting it. It was purring. It was all wonderful. It was a tiny little thing. I decided, okay, I'm going to go ahead and adopt this cat. Now, understand, I have been to Citizens for Animal Protection before. We adopted our first cat from there. I'm a known quantity. I start the process with this very helpful person, and she tells me, I'm sorry, this isn't instantaneous. We have rules and regulations. Okay. No, we have to call your wife. We have to make sure that this is okay. We have all these check boxes to do. And it was a whole list of things, and I was getting very annoyed and agitated. And I decided 3 days into my cancer survivorship, it was time to play the cancer card. So I did just that. I raised my voice just a little bit, and so everyone could hear, I said, "Ma'am, I just got diagnosed with leukemia. And this kitten's name is Luke, L-E-U-K. I'm adopting this kitten today." She leans over, she whispers in my ear, "You will get it fixed, right?" "Yes, ma'am." I now have Luke as my caregiver. Now, I love Luke to death. He's a wonderful brown tabby cat. I mean, he's very affectionate, purrs instantaneously. He has swelled up to about 19 pounds, and he's as dumb as a box of rocks. But he's my cat, and every night when I lay down in bed, he will come up my left side, headbutt my fist, make sure that I'm okay, drape himself across both of my ankles, and go to sleep. If I try to flip over, it's a bit of an issue. Morbid sense of humor, yes, I absolutely get it, because we have to find some way to deal with this. There are still some doctors and there are still some medical providers that will offend us by saying, "At least you have the good cancer." There's no such thing. There is no such thing as a good cancer. We have cancer, and I love that these folks down on this panel have figured out a way to accept that they have cancer and live very, very well. But there's a big but along with this, and that's what I need to talk to Allison about. A lot of this stuff is expensive. FCR may be old school, but it's not cheap. A day in the ambulatory treatment center is not cheap. These novel molecules that we're coming up with, some of the price tags at $10, $12, $13, $14, $20,000 a month. How do you deal with this? Well, you get a microphone.
And that helps. And then that's when all of the great foundations and even some of the drug companies can assist.
How do people get access to those? I mean, we have people on the CLL support group on Facebook all the time saying, "I have no idea how I'm going to come up with the copay."
And they don't, because until you are diagnosed or have a loved one, you don't know other resources out there because you've never had a need for them. And then once you do have that need, you have to connect somehow, either online or in your doctor's office or with other patients, to find out where the resources are and how to get signed up for them.
Do most health centers have some kind of liaison, the role that you provide to assist patients?
OHC does. In most of our offices, we have a financial counselor in all the offices, and we meet with all the patients before they start treatment to guide them down this path. To help them get signed up, to do the applications, to fax the papers in, to get what we need from the patient, to get them the grants going. Or, if the grants aren't available, then we go to the drug companies to see if they're eligible for free medication.
So would it be safe to say that any patient who is dealing with a financial hardship should always ask the medical providers for assistance?
Yes, always tell your doctor. Some patients don't like to tell their doctor or nurse that they can't afford something. But usually they are prescribing those medications because you need them. So I always tell the patients, call us. If it's too high for you, call us, let us know that so we can, see what's available.
Also, we have patients think, "Oh, I have too much money, I'm not going to, be approved." When you're talking about $20,000, $30,000 a month, a lot of these foundations and programs through the drug company have high set levels, because especially in CLL, we're not talking 6 months of treatment, we're talking 10 years of treatment. So it's always good to speak up and ask those questions, because there might be funding out there.
Excellent. Dave, I know that you took an extra rigorous approach to the financial side of your treatment. what are some tips that you can offer folks for managing the cost of treatment? Making sure they have the right insurance in place, making sure that they have the right access to care.
We were fortunate enough because, I've been self-employed for 25, 28 years. So all our benefits come from my wife, who was fortunate when I was going through treatment to work for a very, very large corporation. And so they had plans from bare minimum to Cadillac. So we were fortunate enough at the time to sign up when I was diagnosed, and obviously the new enrollment came, so we took the top, which is a good thing because I went through treatment. The bad thing, as soon as I finished treatment, 3 months after that, they decided to eliminate her job. And I found out very quickly, and this probably goes where you go, is that COBRA doesn't allow you to back down. Where you end is where you pay. And at that time, our monthly bill was almost $3,000 a month. And I had just gone through treatment. I work for myself, so I wasn't doing a lot of work. She was pretty much on, unemployment benefits, and it became very expensive. And that's when I found out last night that we actually could have reached out to get some of that COBRA covered. And so the thing I guess I will say is, to this is, reach out to your financial navigators because they can find ways to pay for this. But
it's good advice. It's time to begin the question and answer session. If the folks here have questions, make sure you get the questions sent to the back desk over there so that they can get fed to me. For those of you online, please remember to send your questions to cll@patientpower.info. That's .info. Now, we already have a lot of questions queued up. We're going to try to get to as many as we can, and I'm going to try to go down the line here. I'm also going to probably demonstrate that I'm in my mid-50s, so my arms aren't quite long enough. The first question is for Dr. Faber. I've heard that CLL is an old person diagnosis, but it feels like a lot of younger people and more younger folks are getting diagnosed. Is this happening earlier to us, or are we just better at finding it?
So the simple answer to that is we probably are seeing it earlier because we in the medical community, I in the community like to think that we have better access to routine primary care, surveillance, preventative medicine. During residency, I remember you would meet folks in their 60s and 70s. When's the last time you saw your doctor? I don't know, 50 years ago. And so now a simple CBC can tell us a lot. And when you start to see that white count drift up and that lymphocyte count get above 5, that usually triggers, the diagnosis. And so we probably do see it more often. I'd be interested to look, and I don't know the answer, is as we diagnose it earlier, that watch and wait or worry approach. And that might be getting more and more because I have a sense that in decades past, CLL was probably there in our patients. It just didn't bring them to medical attention until later in life.
Fair enough.
Yeah.
Dr. Marinelli, there is a great question from Joyce. Most of the time when we get diagnosed with CLL, we get told that it was a random genetic mutation. Joyce wants to know, is there any hereditary connotation to CLL? Is it familial? Can you get it from your father?
So the majority of cases are sporadic, probably due to an acquired mutation, or a chromosomal abnormality or mutation in a gene, or something called a SNP, a change in a single nucleotide polymorphism. However, I think about 9, if you have a first-degree relative, with CLL, your chances of getting CLL yourself is several-fold higher. And if you have a family history of someone in your family, I think your rate is, gosh, I was reading something on this yesterday. There is a higher risk. I don't want to throw the number out there, but I'm thinking if you have a first-degree relative, it's like 9%. And if you have anyone in your family, your risk is higher. Now, that doesn't necessarily mean that it's a genetic familial syndrome like Lynch syndrome or Leigh-Fraumeni syndrome, because a higher risk of cancer in a relative, it's so complicated. It's not always, when we think of inherited disease, it's a higher risk factor just because the genetics are so complex. But yes, there is a higher risk.
Lisa, I have a question for you. We all know treatment can make the digestive system go a little wonky, but treatment aside, do you see an increased level of gastrointestinal issues with CLL patients?
I thought we decided hard questions were going to go to Dr. Faber.
Sorry about that, sir.
I think it depends upon lymph node involvement. If a patient has a lot of affected lymph nodes in their abdomen, if you see people have a splenomegaly, an enlarged spleen, you might see that type of thing. So I think it just is very much dependent upon the patient. Do I have the sense that a lot of my patients come to me at baseline with GI problems? I would say no, but I think it's very individual.
Thank you. Dr. Faber, MJ wants to know, as someone diagnosed with CLL with 17p deletion, he sees a lot of, or she, I'm not sure which, they see a lot of info and patient response on using the drug Imbruvica, but not so much on venetoclax. Can you clarify which drug may be best to use for patients with the 17p deletion?
So I think if we take a quick review of the literature as it stands now, ibrutinib really came onto the scene as having good responses and durable responses for many patients. And then that subset, the subset analysis, which is always kind of a dirty term, in a trial, when we try to get information from a trial, and that wasn't the original intention, but nonetheless, for frontline or even second line, so those folks with 17p, certainly ibrutinib is probably our first choice. And then our patients that might be transplant candidates, we should still have consideration, at least for an evaluation at that point.
Excellent. Dr. Marinelli, one of our viewers online wants to know, is it important to do the IGVH mutation test on newly diagnosed CLL patients that are asymptomatic except for fatigue?
Maybe.
Well, there you go.
So I think it depends. Probably see, as a general, I probably see a couple CLLs a month. The classic one is somebody 65, 70 went in for a CBC, and the white count's high, you get a stat consult, and it's a pretty, for the most part, easy diagnosis for us to make by looking at their count and making an educated guess. For the most part, if somebody is totally asymptomatic, and the fatigue probably is somewhat disease-related, but at the median age of 72, or even some people a little younger, fatigue can be due to beta blocker drugs, can be due to life, can be due to other comorbidities. So if somebody looks like they're not going to need to be treated and they're stage 0 or 1 clinically, I don't automatically send it off, because the standard in early stage CLL is observation, watchful worrying, watchful waiting. If I need to get it to make a decision, I can, and usually there's pretty good turnaround. I sometimes will get it in a younger person if they're like, I have couple people in their 30s in my practice and 40, I might. But the presence of it in a patient you wouldn't treat otherwise doesn't make you treat sooner. You don't treat based on the mutation. But if you think somebody's moving towards therapy or they present with advanced stage disease, yes, because in a fit younger patient where there's a role for FCR, it helps to make a treatment decision. It also has a prognostic implication too, because the mutated do better. So if you're a mutant, you're in good shape. In better shape.
Just to clarify, this is a case where being mutated is actually better.
Correct.
Okay.
Correct. The other thing I would throw out, you didn't answer, is just in CLL, I say this every week to people, you don't treat the white count. With rare exception, so I won't talk about the rare exceptions, but you don't treat the white count. So patients do kind of get fixed on their white count, but you don't treat the white count, you treat other stuff.
And you led yourself into your own follow-up, because I have another question that says, what happens if I don't get treated and my white count keeps going up every month? What happens?
Well, it depends. For the most part...
You gave a nothing and he gave an it depends.
No, go ahead, Dr. Marinelli.
Well, it depends. You know, the one thing that it might cause a physician to pay a little more attention, assuming there are no symptoms, you know, night sweats, fevers, weight loss are the big 3 symptoms that would trigger treatment, or low platelet count or low hemoglobin not attributed to an autoimmune problem, if it's from the disease. Those are your classic indicators to treat. But where that might be useful is what's called the doubling time. So the amount of time it takes for the lymphocyte count to double, if that's short, I don't know, 6 months or less perhaps, you might keep a little closer eye on that patient, not necessarily treat the white count, but if someone was doubling every 2 or 3 months, you know that person probably will need to be treated.
Anything to add?
No. I was just going to say that the way that I explain it to my patients is treating CLL is a bit like a puzzle. And you can have a couple of the puzzle pieces, but if you don't have the whole picture, we're going to watch and wait on it or worry on it. And we do look for the doubling of the white count, and we look for the presence of symptoms, and we look for other abnormalities in the blood and the kidney function, and just the patient in general. How are you feeling? It's really kind of it's a picture here as opposed to one specific thing.
So since you brought up, this symptom inventory, we've all talked about some of the big ones, the important ones. Fatigue, that's generally top of everyone's list. Weight loss is an issue. I try to tell people all the time, tell your team everything. What are you looking for? Are there other things besides those? I mean, give folks some examples of what symptoms are you looking for to fill out this inventory?
Night sweats.
Okay.
And that's not waking up in the middle of the night being hot and having to pull your blanket off. That's waking up absolutely soaked, having to take your shirt off, having to change your pillowcase, that type of thing. So as you mentioned, fatigue, weight loss when you're not trying to lose weight, you haven't made a change to lose weight, the night sweats, and then the presence of lymph nodes. So if you get a big honking lymph node in your neck that pops up, and that's something that we want to know about.
What about?
And those are the B symptoms is what we call them.
What about bruising, little red dots, all this stuff?
Yeah. So, the platelets we worry about with patients with CLL. So one of the symptoms of low platelets is going to be easy bleeding or bruising, a teeny tiny little red dotted rash that pops up on your skin. Those are called petechiae, and a lot of times patients will have that and they'll think, gosh, I don't know what I got into here, but I've got this stuff all over my arms, and then we in fact find that their platelets are really low. So we're looking for that type of thing too. I mean, I kind of just tell any of my cancer patients across the board, not just with CLL, but if you have a symptom that is different from your baseline and it's not going away with treatment in a reasonable amount of time, that's something I want to know about.
Got it.
Because you're going to get all the normal things that are going to happen to a person as they age. You're going to get coughs and colds and back pain and aches and things like that. But if things are not improving in a reasonable amount of time, we need to know about that.
Sure.
To piggyback onto the symptoms, the other thing I think is important, there's a symptom of CLL, but it just is an educational piece. There's a higher risk of secondary or second cancers in CLL patients. No question.
I'm so glad you brought this up.
No question about it. Solid tumors, lung, colon. There's a higher risk of skin cancer, basal cell carcinoma, melanoma, probably from immune surveillance stuff. So staying on cancer screenings, i.e. colonoscopy, skin examinations by a dermatologist, mammography, et cetera, but there is a higher incidence of secondary cancers in CLL. And the GI one, maybe this is a little too detailed here, but sometimes CLL can be confused with a cousin disorder called mantle cell lymphoma. And the cells can look similar if they're in the blood and in the lymph node, and they mark up the same with a couple exceptions. So mantle cell lymphoma can involve the bowel and get polyps in the bowel and can potentially cause, pain or bleeding. And I think that goes back to when you're diagnosing CLL, to make sure it's done in a hospital that has a hematopathologist, because there's nuances, but CLL can be confused with mantle cell lymphoma, which can cause GI symptoms, and they're totally different diseases.
You mentioned bleeding as a possible issue, and some CLL patients have problems with platelets. What about the other side? Are blood clots CLL related? Is there an added risk to having blood clots as a CLL patient?
Anecdotally, I think there probably is. I mean, I've seen several patients with DVT, PE that have CLL. I've looked at the literature, and it's variable, but it might a little bit. I don't know for sure. Now, if somebody's on treatment, you're giving them chemo or some medications, or they're having B symptoms, that just in and of itself, through all the cytokines and all that, increases the risk. But your average stage 0, I think it does a little bit, but I don't know for sure.
Okay. Jim has a great question for Dr. Faber. What are the risk trade-offs for patients who have responded well, blood counts normal and stable? What are the risks of stopping ibrutinib and taking a so-called drug holiday until blood counts start doubling again? Is this a reasonable approach?
Yeah, so that's an excellent question. If somebody has the answer to that, I would love to know right now. But it's really, and it alludes to the concept Dr. Marinello brought up, our immunotherapies, checkpoint inhibitors, targeted therapies, they kill cancer cells differently. And so we have examples where you have to stay on the drug, because just like certain antibiotics kill bacteria, others just stunt it and let your immune system clear. As these new drugs are used and used more and followed up, I think time will tell us exactly what will be the right answer for that. For my practice personally, I have left individuals on indefinitely, so to speak. There's some data in the literature for that. I will say some of the bleeding risks from ibrutinib, though, that those couple patients taught me that we have to be mindful of that. You can acquire some bleeding disorders. Other patients, either they just don't want to be on it anymore, or maybe their liver tests were a little bit up, or that fatigue issue that everyone describes. And I've done holidays, and drug convalescence is the fancy term. And so I've had good experience with either way. I might be able to answer that question in 2 or 3 years, though.
Excellent. Dr. Marinelli, we're going to follow up with it. You were asked about, should I be tested for my mutation status? So there's a great follow-up question from Rich here. He says that he's recently been diagnosed with CLL. With all the new drugs, diagnostic tools, genomic tests that are available, he wants to know what tests should be performed before starting a first-line therapy. We haven't actually gone into that. Which tests do you want to see for just before first-line therapy?
Well, it depends. I give all these vague answers. It depends on what your first-line therapy is going to be, age of the patient. I would say in general, if you're going to treat a patient with FCR, first of all, I'd probably look at age. Probably wouldn't treat anybody over 60-ish for the most part. What their bone marrow function is, their liver function is, the kidneys for the F part of it is important, because that drug is eliminated through the kidneys. If you're going to get any drug that contains a toxin like rituximab or obinutuzumab, it's mandatory to check for past exposure to hepatitis B, because it can be reactivated and be fatal and really bad. So looking for that, with the newer drugs, the oral drugs, For ibrutinib, one would, in addition to the CBC and the liver enzymes and kidney function, probably get a baseline cardiac evaluation, not necessarily see a cardiologist, but if the patient has some risk factors, I might do an echo. I definitely would do an EKG to make sure there's no baseline atrial fibrillation with ibrutinib. Other baseline tests before that drug, coagulation studies because of the bleeding risk. Venetoclax, which is Venclexta, a newer drug that's being used. Kidney function, definitely. If someone has a pre-existing kidney failure, there's a phenomenon called tumor lysis that you would need to know their kidney function, their uric acid, et cetera. So those are some of the general things. Not everybody needs to get echoes and pulmonary tests and all that. The average patient doesn't. The one thing, when someone is starting on an Imbruvica, maybe it doesn't go here, ibrutinib rather, because we're talking about counts and doubling times, is that, and if anybody has started ibrutinib, the white count will go up. That's normal. And I've seen a couple of patients that have been started on the drug and they go in to see their primary care and you get a phone call that you need to see this person immediately because their white count went up 50,000. And then they come in and you're like, no sweat, because it's dislodging the lymphocytes from the lymph nodes in the spleen and putting them into the blood. So on ibrutinib, if you're starting treatment, your white count can go up for a while. Your spleen will shrink and your lymph nodes will shrink predictably, and then the white count will come down over time. So it's interesting to watch. So that's another white count thing specifically with that drug.
Yeah, and I'd like to echo that a little bit because that's the tumor flare, right? And I've had and been involved with patients' second, third, fourth opinions where therapy has been stopped probably early, and you do have to ride that out. I mean, I've had patients I've watched and wait, white counts into the 300-400. So when you do have to start treatment, it is scary to see those white counts going up for a month or 2 or 3, or even the lymph nodes. I mean, you can get that, lymph node wiggle, so to speak, and those lymph nodes, they can get pretty big and painful. A little bit of steroids is your friend there, maybe not for your sugar's friend, but the tumor flare is something that definitely requires, I think, you have to live through it once or twice before you get comfortable with it, I think.
Is it safe to assume that all patients should have the FISH and flow tests done?
I think so. At the time, it may not help you with the exact timing of treatment, but when you are going to start treatment, FISH, CD30, ZAP70, mutated heavy chain, those are basics. And the one thing that I may deter a little bit from that is, trisomy 13 is supposed to be the best of the best, right? But we have some folks that require treatment a lot sooner. We don't know exactly, but there is a molecular test, SF3B1 or so. It's not always available, but if you're mutated for that and you're trisomy 13, you might need treatment a little sooner than the literature tells us. So in that setting, that does help maybe guide when you're going to treat. But I agree with Dr. Marinelli, you don't always have to have everything all the time.
And they are expensive tests.
That's correct. And they're not always available repetitively and routinely all across the country also. So our lab may have it, but it may not be accessible to another, or they're different assays and they don't have the same meaning. So
while we're talking here, Dennis wants to know, are frequent severe infections a basis to initiate treatment? Now, I realize that's a broad question there because we don't know what type of infections, but are frequent and recurring infections an issue?
So it's an individual issue. Again, it's the art of medicine. We can get antibiotics, Z-Paks and amoxicillin and leave it thrown at coughs and colds and sniffles that are not really true infections, right? And so what is a true infection, I think, is the answer to that question. And so when you start having sinus issues that 3 courses of antibiotics haven't fixed those, that might be a time to start thinking about that. You need IV antibiotics. Those to me are the real deal, infections that your immune system is down, probably due to your CLL, and it might be time to at least think about treating. The old joke was many CLL patients, their first treatment for CLL is 3 courses of antibiotics. So.
Yes, sir.
One of the things I would add there that I do in most patients, definitely if I'm going to treat them, is what's called quantitative immunoglobulins, which are basically antibodies. There's 5 kinds, but you look at IgA, IgM, IgG, and patients with CLL inherent to the disease often have low immunoglobulins. So knowing that, and if someone has recurrent infection, even if they're off treatment, checking those, and if they're low and a recurrent, I agree totally. Most of the stuff that's getting treated probably is being overtreated with the sniffle, but recurrent severe pneumonia or pulmonary infection, severe sinus infection, maybe a GI infection in the setting of CLL and low immunoglobulins would be an indication to treat with immune globulin, whether the person's on therapy or not. And some of the therapies can cause that too. For FCR, someone who's on Rituxan for 6 months it depletes the lymphocytes and makes those immunoglobulins low. So you might have someone in remission but has recurrent infections for the next year or 2 because their immune system isn't working. Might be another indication to give IVIG.
Dr. Faber, I have an interesting question here, and it's one that we get regularly when we do CLL town hall meetings. The subject is a little bit controversial, and I always like starting this little discussion with a minor statistical overview. Correlation does not equal causation. Remember that. Keep that in the back of your brain for a second. Craig was diagnosed with CLL around the end of March in 2019. His white blood cell count was at 11.1. His wife got him started on CBD oil, and now it's down to 8.7. What other explanation can you give me as to why it went down besides taking CBD oil? Haven't changed anything else.
Sure. So I think it's well known in our literature over time that once your white count is high, it doesn't always have to stay that way. If you were blood and our blood counts are a very dynamic process, it's not static. We make cells, we use them, we recycle them. And the balance can be disrupted for a variety of things, allergies, viruses, foods, other medications. And so, as I explained to some of my patients, if I took a blood count from you every hour for a day, first of all, that'd be very mean, but I would have a different white count every hour probably, and I might get something close, maybe 4.2, 4.6 or so, but there can be some ebbs and tides to your white count naturally. It's, and this is what Dr. Marinello was alluding to, the doubling time. When the trend over time is true, then it could be either up or down. As far as, homeopathic and things outside of chemotherapy, the one thing I'm aware of is actually green tea. I believe it was a Mayo study that published that. It started with a trial where I think responses were better, and they attributed it to green tea, for example. I know green tea, it gets in the way of some of our other drugs we use for other cancers, but outside of that, that's the best explanation I can have.
So do we know yet whether CBD oil and marijuana has a positive effect upon treating CLL?
I'm not aware of that. So
we have a question in the back.
So this is an in-person audience question. We talked a little bit about symptoms before, but what are some of the early signs that you have CLL? And then if you have it early, are there any tests that you can do to see if your CLL is in the early stage? So kind of like a two-parter question.
I think as we discussed before, many times this is diagnosed based off of a CBC. And for my practice, I see all of our new blood consults that come into the office. So if you have a blood problem, you come to see me first. And many times the patients have no symptoms, and it comes as quite a shock to people when they come back a few weeks later and we tell them that they have leukemia. So I think as we said, you're seeing that trend on the CBC that kind of cues the primary care doctor to make the referral. I've had many patients that have had these high white blood cell counts in, what I call low high, so, 12, 13, 14, something like that for many, many years before they actually make it into our office.
Because CLL does lean towards the older members of our community, many of those patients are on Medicare. Does Medicare deny care because of cost of drug or the patient's age?
No, Medicare will go more with the drug and the diagnosis if it's FDA approved and on their guidelines. It won't have to do with the age or cost.
And that took care of that. Another question?
Yeah, so another in-person audience question that was passed on. So she can't get into VA, but she's still on a fixed income. How can she afford medication or treatment if she can't get into the VA?
Look at the foundations and contact the drug companies, because they do have programs for patients that are on Medicare. Most drug companies will have two programs, one for commercial patients and one for Medicare patients.
I have a question from online here. This is a great question because we probably didn't make this clear. Sarah wants to know, what is the difference between indefinite therapy versus fixed duration?
Sure. Yep, no, absolutely. I think as we develop medications that might be better tolerated, in quote unquote, previously with our older traditional agents, you had a defined number of cycles, 4 cycles, 6 cycles, and then there was a stop, and then you would see what happens. As medicines have different side effect profiles, maybe globally easier to take, injections, pills, folks leave treatments to extend on, so-called maintenance therapy. So as trials are designed and as the experience is used, fixed therapy is an intention of, 4-6 cycles and then stop, and then clinically follow with scans and exams. And then indefinite therapy is you are going to stay on the drug, maybe with some dose changes depending on side effects until, in this case, your CLL would return and not respond anymore.
Thank you.
Another in-person audience question. What is the percentage of people diagnosed, but it never goes beyond stage 0 or stage 1?
The lucky ones, in other words.
I've seen, I think, anywhere 15 to 20 some percent. Like it's, I don't know. What would you say? Would you agree? 1 in 5, 1 in 6?
That never need to be treated?
To me, the answer to that question is, when was the time of diagnosis? So you have somebody 76 years old, early stage. To me, that patient population in the 6th and the 7th or 8th decade of life, that percentage might be much higher than somebody in their 30s, 40s, or 50s, right? So.
In-person audience question, is there anything significant between SLL and CLL, or are they truly the same?
So I think there are some really incredibly intelligent lymphoma doctors that would disagree with this statement. That were role models and mentors of mine, but clinically speaking, for many of you as the patients, CLL and SLL, we're always taught is the exact same thing. The same treatments, sometimes eligibility for clinical trials. The drugs that we have now, they can be interchangeable, the same treatments for those. There are some subtle differences. I think the CLL patient that has a white count of 600 and then you treat, or the individual with SLL that has lymph nodes of 5 or 8 centimeters, those probably are distinctly different. How to test and explain that to us, I don't know that we have that technology just yet. But the simple answer is yes.
Dr. Marinelli, Christine wants to know, what are you looking for in a flow test? What's the information you're looking to get out of a flow test? She just had one.
So in general, to diagnose CLL, you don't need a bone marrow biopsy. there is a role for a bone marrow biopsy, but the answer to this question, the typical situation, someone goes to their primary care doctor, they get their annual blood count, white count's high, go see this guy at this office, and their white count's high, the platelets are normal, hemoglobin's normal. Then we look at what's called the differential, at the 5 different types of white cells that circulate. And most of the time, in someone who looks well and looks fine, and the CBC is normal, you'll see a high, what's called lymphocyte count, ALC. If that's greater than 5,000 on 2 occasions, that's when you would think of CLL, because there's some precursors. One is called monoclonal B-cell lymphocytosis, which is about as hard to explain as MGUS, but it's a precursor. But if it's greater than 5,000 on 2 occasions, the next step to make the diagnosis is a test called flow cytometry. Someone talked about it a little bit ago. They put your blood through this analyzer, and the blood pathologist reads it, and it looks for certain markers on the surface of the cell. CLL is characterized by a marker called CD19, CD23, CD20, and CD5.
CD20.
And no, CD23, mantle cell is CD23 negative, isn't it?
Yeah, it's CD5, 19, 20, 23. 10 makes it mantle cell.
10,
it's 5 negative and 10 would be positive. Sorry, just a lot of shop there real quick. But we there's 3 and now probably more than 400 of these CD markers, and the trends of those and the different combinations tell us the different populations of blood cells, and especially white cells that circulate in all of us. And so we go through these charts, and I don't think we could pass our boards unless we can get through that. So at one time we have all these numbers decorating in our heads. So
we've got one more question. You get to use the microphone.
Okay. I have lived in Latin America for extended times and in several European countries, and I've learned the languages in those countries and, of course, Spanish. Yet right now I yearn to go back, especially to Europe. But I'm afraid of the circulation of the air in an international flight that's 8, 9, sometimes 10 hours long, in which the air is recirculated. And I'm told that just wearing a mask, such as a mask that is used by surgeons, wouldn't actually protect me from disease, germs floating in the air. Is my fear unfounded, or is that something I need to be concerned about?
I think this is a great question. Should he be concerned about international travel?
Yeah. So I think it's well known, either your CLL or the treatments that you may or may not be on do impair the immune system. And as Dr. Marinella explained, there's ways that we can help with that. We have 2 body systems that are open to the outside world: our respiratory, our sinuses, our lungs, and our GI tract. And so we normally have our immune system coat that to protect us from the outside world. I answer that question based on if your CLL is stable, if you are not on any treatments, I would probably, I don't think your risk would be that much more. If you have shuttled through 3 different lines of therapy and your doctor is struggling to control your lymphadenopathy, your white count, there are days that you can't get out of bed, then your immune system, your IgG levels are, 200 or something, then your risk would be a lot higher. A simple mask, I think I'd be interested to hear everyone else's opinion. I find value in that. There's something called the N95 mask that prevents you from things like tuberculosis. I can't imagine 9 hours with that mask on. I can't wear that mask for 9 minutes when I have to see a patient in airborne isolation. That would be mean, in my opinion, to just ask you to wear that thing. So, but there is something that is doable. That's that N95 mask. That would be like the ultra protection, so to speak. But a simple mask and washing your hands, the few things that are airborne, you know, the Listerias and the Legionella, I mean, honestly, it's really hard to get a lot of those, so.
I do receive a monthly IVIG.
Yep. So your IgG levels should be solid then, and, yep. Hand washing, I cannot, hand washing is the biggest barrier against passing infections. That and 3 to 5 feet from somebody, because a lot of the aerosolized viruses fall to the floor by 5 feet. You know, and if a simple mask isn't as helpful, when the SARS outbreak happened, you know, everyone was wearing a mask, and that helped control that. So if it's good enough for SARS, it's probably good enough to travel to Europe, I would think, too.
And look straight ahead. Don't talk to anybody on the plane.
Yeah. Just watch the TV. Yep.
I'd like to thank everyone for participating in the town hall meeting. This has been absolutely great. I want to thank all of our sponsors for making this meeting possible, and I'd like to thank our wonderful partners and the CLL Society folks out there in the foyer, Leukemia and Lymphoma Society, Needy Meds, Adaptive Biotechnologies, Genentech, AbbVie. We can't do this without them. If you've liked what you've seen and heard, we have a wealth of content that is currently available online. Please visit patientpower.info/CLL. There are a ton of videos that provide great content. Feel free to email us at cll@patientpower.info. You can also send questions to me at that address, and I promise they'll get to me. I mentioned Leukemia and Lymphoma Society, Needy Meds, and CLL Society. If you want to learn more, they're here to help. Let's see. There's one more part. I'm going to ask you to join the community on Patient Power. If you go to patientpower.info/join, you can become an official part of this community. We do not share information. Lots of people ask for it. We never give up your personal information. So, once again, thank you to everyone that attended the program here in person and online. My friend, Andrew Shore, who started Patient Power. He is fond of closing every one of these events with knowledge can be the best medicine of all. Well, knowledge is the best medicine of all, especially if you're vacationing in Sweden. So I hope you're having a good time, Andrew. Thank you, everyone, and I applaud all of our guests and panelists.